Let's call upon Dr. Chandra Devi. And the topic is risk factors, management and prognosis of patients with post-cataract surgery wound infection. Can we have the timer also? All right. Yeah. So.
Good evening, everyone. I'm here to present my study on the risk factors, management, and prognosis of patients with post-cataract surgery wound infection. I would like to thank AIOS, APO, and Professor Namrata Sharma for this opportunity. Cataract surgery is one of the most common elective surgical procedure which is performed worldwide. SICS is a commonly used technique in developing countries like India, whereas phacoemulsification is commonly practiced in developed countries. Higher rates of post-operative endophthalmitis have been reported with SICS compared with phacoemulsification. Post-cataract surgery infection have always considered endophthalmitis, whereas wound site infection is often underdiagnosed or not reported. So my aim of the study is to evaluate the socio-demographic profile, risk factors of patients presenting with post-cataract surgery wound infection, to identify the causative organisms associated with the infection, to evaluate the outcome and prognosis in these patients. It is an ambidextrous institutional study which is conducted over a period of 18 months. The patient with post-cataract surgery wound infection who is presenting to the emergency department or the OPD were recruited in the study. Demographic details, risk factors, place of surgery, time of onset, everything was noted, and microbiological investigations were done, and the patients were managed accordingly. The follow-up period were, the patients were followed up for a period of 6 months. So we collected around 18 patients. The average age of the patients were 63 years plus or minus 5 years, and the type of surgery done was most commonly SICS in 17 patients, and 1 patient with presented with phaco wound infection. The average time of presentation is within a week in 14 patients. The site of infection involved is a superior sclera, which extends to about 1 to 2 clock hours, and there was about superior corneal infiltrate in 66.67% of patients, and 72% of patients presented with hyperpion, and 44% of patients had associated endophthalmitis. So this is a microbiological report where the gram staining revealed gram-positive cocci in 2 patients and K-watch was negative. On culture sensitivity, 10 patients, culture sensitivity was sterile, whereas 3 patients were positive for Staph aureus, 2 patients were positive for fungal infection, which include Fusarium and Aspergillus, and 1 patient was positive for Pseudomonas, and 2 patients were positive for Staph species. So 7 patients were managed medically. 1 patient required blue BCL. 2 patients were treated with therapeutic PK, and 4 patients were required intravitreal antibiotics, and 4 patients required endovitrectomy. So the duration taken for recovery in our patients were about 30 days to 90 days. The common risk factor identified was the patient who has been operated at a district hospital or small center carried higher risk, and scleral thinning and uncontrolled systemic illness also carried a higher risk for infection. The average visual gain was around logMAR 2.4 plus or minus 0.8 units, and most of the patients responded to topical and systemic antibiotics. Early onset infection carries a poorer prognosis compared to late onset. There was 1 patient who has developed fungal infection, had an extensive corneal and scleral involvement. That patient eventually resulted in phthisis bulbi. So this is a patient who had scleral tunnel infection with superior corneal thinning. The patient was treated with blue BCL. This is 2 patients who had late onset tunnel infections. And this is a patient who had phaco tunnel infection. You can see here the phaco wound, and there is uveal tissue prolapse through the phaco wound. And this is a patient who has been managed with endovitrectomy and with silicone oil in situ. We can see the silicone oil in situ in the AC. There is 1 patient who presented with scleral necrosis. It is basically a sterile necrosis due to excessive cautery. The patient has undergone scleral patch graft, but the patient is following with a good vision of around 612. So outcomes of post-cataract surgery wound infection is generally poor. Early identification of the complication and prompt referral helps in vision or globe salvage. Bacterial infection is more commonly encountered in these cases. So we should follow uniform guidelines for ASS's use of preoperative or intracameral antibiotics can reduce the risk of infection. Thank you.
So what were those predisposing conditions which you were seeing in majority of these patients who reported to you with these infections?
Many of the patients have been operated in a peripheral centers where we doesn't know about the aseptic precautions which has been followed, and about the preoperative antibiotics which we have been used or not, and they have been operated in camps. So preoperative precautions should be followed.
Was betadine used for these patients or not? Because that takes care of a lot of these problems.
Yeah, but all these patients were referred patients, so we don't know about the intraoperative.
Okay.
All right, thank you.
Thank you,
Thank you so much.